This conference will now be recorded.
Hi, everyone, and welcome to the AnCan High Risk, Recurrent, and Advanced Prostate Cancer video chat for Monday, May 18, 2026. I'm Len Sierra, and I'll be moderating today with a little help from my fellow moderators, Rick and Dr. John, and all of you are well-educated, well-informed attendees. As a reminder, this video chat is for informational purposes only. Nothing contained in this discussion should be construed as medical advice. We want to acknowledge and thank our sponsors. I hope I got this right. We have Foundation Medicine, Novartis, Telix, and Blue Earth Diagnostics. All right, Rick.
Foundation Medicine, Novartis, and no,
Telix.
No, not Telix right now. No Telix.
Yeah, I thought it was only 3. Okay.
We hope soon. We hope they'll be back. I will say that we're obviously doing something wrong because I just happened to look at the Man Up to Cancer quarterly newsletter, and their list of sponsors is unbelievable. So I don't know.
Okay. We're going to start with Jan Nielsen. Go ahead, Jan. What's on your mind?
I just have a question. I started running into articles about liquid biopsies and biomarkers in prostate cancer. And I wonder what this group thinks about any of that.
Can you be a little more specific? Because we clearly think that biomarkers are very important, but there are many different types, and we definitely think liquid biopsies are a great alternative. But what specifically are you asking?
Yeah, well, there's a plethora of them, as you well know, and I'm just not sure exactly which ones are most reliable and in what cases, especially around the liquid biopsies. If I were to talk to a friend that was in early stage diagnosis, who would be most eligible and most benefited from a liquid biopsy?
Well, it's really dependent on what they're looking for, and how we define liquid biopsy. To me, liquid biopsy is probably not something that you're going to request at an early stage unless you are advanced. Well, I shouldn't say advanced, unless you have high risk or very aggressive disease, or we already see metastasis. I don't know that there's a role, and I'll throw it open after this, and anybody can contradict this, but I don't know there's really a role right now for liquid biopsies in grade group 1, 2, or 3 prostate cancers. Now, there may be, because there's so much going on, especially in grade group 1 and grade group 2, with all the various biomarkers, and I'm not sure which ones, if any, are done with blood or not. But the purpose is always to determine the aggression of the level of aggression of disease. Now, with respect to further down the line, a couple of things. First of all, frankly, anybody, but I think the guidelines are anybody with high risk cancer or other certain risk factors, such as their ethnicity or their family history, should be getting a germline test. But that germline test can also be done with a mouth swab, I know, as you would be aware, Jan. But it can be done with a blood test. in terms of people who have more aggressive disease, there are times early on in the disease path when it's important, and maybe very important to know what somatic mutations you have. And in fact, there are guidelines that for anybody with metastatic disease, a somatic analysis is necessary. And there are times if your PSA is high enough that a liquid biopsy can replace a tissue biopsy if tissue isn't available. And the research generally shows, going back quite a long way to the dear departed Felix Fang, who was one of the first people to publicize on this, I think with Agarwal. I think it was a Fang Agarwal paper, that there really is no difference between tissue biopsies and liquid biopsies. That most of the times they're consistent. Now,
Yeah,
what
that's
are
what
we
I was
looking?
wondering mainly is, it's a lot less invasive, obviously, and I wonder if there's a good examples of where a liquid should be done instead of a tissue biopsy.
Well, the problem with a liquid biopsy is that there has to be enough circulating tumor cells. So it really depends on how aggressive the disease is. So a man who comes in de novo metastatic with, if he's high volume, is probably going to have as much information in his blood as he is if we take a cell. That said, it's very interesting at the back end where we have somebody who is progressing and well advanced, and we're concerned, is their cancer morphing? Is it becoming more of a small cell? That we're better off with tissue, because you cannot tell by looking at the CTCs if those cancers are morphing, but you can see it if it's from a piece of tissue. We can send it to Epstein or Zhao, and they can tell us. And sometimes we'll ask our guys with advanced disease where we're not sure, should we be switching up the treatment? Can we get a tissue biopsy so we can send it to Dr. Epstein or McKinney or Zhao? It's very complex. I'll stop right there because I know that
John's got his hand up for a while. Go ahead, Dr. John.
Just to follow what Rick is saying, I'm glad you're thinking about this, Jan, because you are metastatic, and as far as I know, never got any testing. So anybody that's metastatic, I think, should have some sort of genetic evaluation, whether it's tissue or blood. In your case, you're non-detectable, your tissue is 6 years old, and your cancer is very slow, so there's nothing to get frantic about. But I think it's good that you're thinking about getting your tumor cells checked. But your whole clinical picture doesn't indicate any kind of aggressive process.
Yeah, if my PSA went up, I was going to do PSMA testing next, but I'm thinking also in advising other people, not just my own particular situation, but people have come to me and said, should I get a liquid biopsy or a tissue biopsy when they're fairly early on? And I don't know the literature well enough to comment on that.
fairly early on.
Just what Rick said. Get tissue if it's easily accessible and new, like a metastasis, and get liquid if you can't, or if you have any special circumstances like Rick was talking about.
Yeah. I mean, the testing companies will tell you that the very best sample to get, if you can, is soft tissue. Second after that is a liquid biopsy, and third is a bone, because they have to macerate the bone. And in macerating the bone to be able to analyze the genomics, there can be distortions. But the best thing to get is if you can get it, is a soft tissue sample.
Okay. Thank you very much. I appreciate the comments.
Right, we got a few more for you. Dr. Jack, go ahead.
This is related, but not quite related to what you're talking about, but it's about liquid biopsies. And I've been made part of a study, this is interesting, where they're using Signatera or Natera is doing a study on seeing people who have been metastatic and are PSA negative for a long enough period of time without treatment. Like I'm receiving right now. I'm 14, 15 months out without treatment, and I'm getting every 3 months a liquid biopsy with Signatera to determine whether or not it can compete with PSA in determining the reoccurrence more rapidly than PSA would. And it's interesting. I don't know if I'll have sufficient. I hope I don't have sufficient tumor burden to make that a reality, but it's an interesting study. So I didn't know whether you were aware of that, but my medical oncologist included me that, and I said, sure, why not? It sounds like a good idea. So I had my first blood test, and I don't know what the results will be. I see him in June.
You put something in the chat about that study. I can follow up, please.
No, it's not a universal thing. I think selective medical oncologists who have a relationship with Signatera have been assigned to utilize their patients accordingly.
Okay.
So this is an application of the concept of looking for minimum residual disease, right, Jack?
Right. Yeah, exactly.
All right,
Yep.
thank you for that. Jeff Markey, go ahead.
Yeah, the problem with new metastasis is that they haven't shed into the blood very much yet, so they may not show up. So if you have a new metastasis, you may want to have a sample from that rather than your blood sent in.
Well, but Jeff, that's not strictly true. And the reason I say that is because we don't know how long a metastasis has been present. Now, if you were getting PSMA tests on a weekly basis, which nobody does, then we'd know. I would agree with you, but the likelihood is that if you see a metastasis that wasn't there when we last looked, there's been a good period of time, and we don't know how much has gone into the blood. So I'd have to disagree with that.
I heard it during one of the conferences that was an issue, but you're probably right that you don't know for sure how long it's been. It could be nothing shows up though, and then you might have wanted the.
Well, I mean, that's always the case. I mean, if you do a blood, let's say you've got a metastasis that's in a really difficult place to biopsy, then your first choice is going to be blood. If nothing shows on that blood, we still have the option, as difficult as it may be, to try and get a tissue sample.
All right, let's move on to Frank and Lisa. If they're there, I don't see them. There they are. Okay. You have an update for us, Frank?
Yeah, my wife's going to talk.
Just a quick update. So
Okay.
he had, I'll try, I am going to be quick. He had the liquid biopsy, which I know you guys know that he had the 2 genes that are not good for prostate cancer. And Dr. Yang really didn't address them at the office visit. But I did reach out to him, and he sent me a message back on Friday night, because I said, you didn't address those at the visit. And he said that, yes, you're correct that the TP53 and RB1 are not good prognostic indicators. but these two markers do not equal small cell or neuroendocrine cancer. Small cell or neuroendocrine usually produce no PSA. And he said, I don't have high suspicion. Ultimately, the diagnosis would be a new tumor biopsy. But he said he didn't think he needed that now. He said, let's see how his PSA is doing in the upcoming scans and how he's responding to the chemo. That was his answer for
Right.
liquid biopsy.
Right. Now, of course, this is a doc who didn't even want to do this follow-up sampling, and he hasn't done a repeat somatic test since 2023. So,
Right, yes.
Right. So
that's all he said.
Right.
That. But at least I addressed it with him.
So here's my thinking on this, and I'd love to know what other people are thinking. Frank's pretty far advanced, you know that, but you're doing good on the Gevtana. And just as an aside, I just read a trial right before the meeting started where they were looking at niraparib, ipilimumab, both of which are immune diseases, abiraterone alone or Gevtana alone. And those niraparib and ipilimumab are pretty fancy drugs. And pretty much across the board, except in one instance, and they were looking at overall response. I'm not sure what that was because I didn't have the whole trial. They were looking at radiographic-free progression. The Gevtana came out the best, Frank. So I'm thinking to myself, I hope it does the same thing for my buddy Frank.
I hope so.
Here's my problem. I think you had enough treatments and there's been enough changes that we ought to be testing you to make sure that there's no evidence of small cell or neuroendocrine morphing of the, and I'd really and if they're the only way we're going to know is do some of these tests like chromogranin, some of the other things that DLL, and you've got a doc who doesn't want to do anything except leave you in his bloody trial. He doesn't even want to get you sequencing. And I don't buy that.
Address those. All that information that came from that Dr. Tanya, I have it all written down. And when we go back in 2 weeks, I'm addressing every one of those markers.
So let me ask the group here. I mean, those of you who know Frank's background, do you think it would be worth checking at this point in time to see if there's ever any evidence of something of morphing and early evidence of small cell?
Yes.
I agree.
Say more, Frank. Say more, Len, please.
Well, the longer we're living with this disease, it gives the cancer more time to change its morphology, have multiple treatments that may have killed off cells that were sensitive to a particular treatment. And then the cancer finds a way around that. And in order to do that, it changes its morphology. And then, new mutations develop. And that's why you need to check for these things periodically in advanced prostate cancer. So, Frank, did you get your third dose of Gevtana yet, or it's in the future?
Yeah, I got
No.
Wednesday.
Got his second dose on Wednesday.
Second dose was Wednesday. Okay.
Yeah, the second dose is June 3rd. He'll get his PSA, or third dose, June 3rd, and then his scans are June 5th. Also, I know we talked to Rick. It's fantastic that you hooked us up with that Healthier, the AI group.
Yeah.
They were so wonderful. We met Friday. he sent all the information. They've actually started to analyze it all. We can follow it. They said that once all the information's in, it'll go to 2 doctors in California. One is from the City of Hope, and that doctor will review it, and another doctor. And then they're going to, come up with recommendations and trials and they said they would even maybe be able to find a doctor that fit with Frank's needs.
Okay. Well, we'd love to know who that was. I think you do need to tell them that the City of Hope has a conflict because they're running one of the trials. I think it's important you point that out, because I don't know that Healthier will know that.
Okay.
So you can just send Ali a note and say, Ali,
Okay.
by the way, it would be ironic if the person they're using at City of Hope is Dr. Dorff. That would be very ironic, but I doubt it.
Right.
For those of you who are wondering, what the heck are we talking about? I had a meeting on Thursday that we've been trying to set up for like 2 or 3 months with a group that's developing an AI model that is supposed to assist patients in communicating with their doctors and getting into some of the more detailed areas that the doctors would not normally expect the patient to go to. And also doing some of the things that a lot of the other AI is doing, pulling up the right trials that you should be looking at, and the things that some of you are fairly familiar with that use AI. My first response when I listened to their presentation is, this is great, but it isn't the patient that needs the information. In most cases, it's the doctor. If you're dealing with a community doctor, with a community practice doctor, it's going to be a real issue to go in with information like that, because the doctor's going to be intimidated, not going to know half the stuff. So yes, it's great, but we got to do this hand in hand with explaining stuff to the doctor. Now, they have 2 versions of their report, one for the doctors and one for the patients, but it's basically the patients right now that they see as initiating it and not the doctors. So this is what we're doing, and we had a couple of people that we thought might be pretty good to trial it. And one of those was Frank. So we connected them, and that's moving forward. And then we've also got a couple of people that, and I think I forgot to do this, I have to make myself a note. We got a couple of people that we wanted to connect them with who are pretty familiar with using AI and might want to take a look at the reports that are coming out and tell them how it compares to using Claude or ChatGPT or whatever else is involved. Yeah, and Danny's mentioning open evidence. That's the same platform that Dr. Jack uses and has mentioned to us. And yeah, we're aware that you have to have a provider number for that one, but yes. So that's what the Healthier is about.
They said the information should come back pretty quickly too, because I know Len has that doctor in Florida. We are really, I mean, we're ready to go there. I mean, we'll go. We're going.
Well, I don't know that doctor in Florida is the right one.
Okay.
Okay. I mean, she's very good, but she may not be the right one. We've got to figure out the right one. We want to see who they suggest. Dr. Guanchel is really good, but at the same time, we've got doctors who are equally as good who may be closer to you.
Okay.
And so,
yeah.
But she happens to be running that pasritamig trial.
Okay.
Interestingly enough, Bill and I were on call this morning, a meeting this morning with a think tank who are doing some stuff with AnCan. And we told them, yeah, we've got a guy who's on your, and they're going to be talking to AnCan this week. We got a guy who's on your 509 trial, but he got assigned the control arm. Now, what we have kind of figured out, maybe you can talk to this a little bit, Len. We've been looking at pasritamig against xaluritamig, okay, because they're fairly equal, except the pasritamig now belongs to Johnson & Johnson, and the xaluritamig is still with AnCan. These are drugs that are called bispecific T-Cell Engagers. This is for all the group. And their target on the cell is not PSMA, it's another protein. And in the case of the pasritamig, it's a protein called KLK2. And in the case of the xaluritamig, the AMG 509 that Frank was trying to get, it's STEAP1. Now, it sounds like I'm very knowledgeable, but I don't know much more than this. So Len or Dr. John or anybody else, do you have anything that you'd like to say about these bispecific T-cell engagers?
Well, yeah, first of all, they both grab the CD3 protein or antigen that's on the T cell, so that's good. Bring the T cell to the cancer cell. But yeah, on the cancer cell, in the one case, as Rick mentioned, you have it bites onto STEAP1, and in the other case, pasritamig, it attaches to kallikrein-2 or KLK2, which in advanced prostate cancer is more ubiquitous than is the STEAP1. STEAP1 is pretty good. I mean, it's like 80% of advanced prostate cancer, but the KLK2 is what I read, nearly 100% on advanced prostate cancer cells. So I think that would be the advantage to the pasritamig over the other one, the xaluritamig. That's John, Dr. John. You have anything?
No, nothing to add. Very scholarly, Len. Thank you.
Yeah, and the pasritamig is being run in Cleveland and Cincinnati, we think, with through Johnson & Johnson. So in a way, Frank, you might be better with the pasritamig than you would have been with the xaluritamig.
Yeah, everything happens for a reason.
Yes, sir. So anyway, we can keep going, but
I just want to add one thing. I know Ricky had some concern that Dr. Guancho might try and slot Frank into her pasritamig trial as opposed to one that you and I might think is a better fit for Frank. But I have such high regard for her integrity. I don't believe she would ever do anything like that. I believe she would do whatever's best for Frank. So
okay.
That's why we want a second opinion, just to go talk to someone and see what they think fit in. So hopefully we can figure that out.
Right, Lisa. But what I'm saying is I want you to get a second opinion from somebody who couldn't possibly have any conflicts. That's kind of where I'm coming from on this.
Or you could
I don't
do
want
both.
to see any possible conflicts. I don't know if we're going to find anybody like that, but we're sure going to try and rule it out.
Okay.
Dr. John, go ahead.
I just wanted to know, Frank, if there was any more PSAs since the 24 one.
No.
Okay. We'll get one in early June.
That's another problem with this trial, which is that they got Frank in there and they're not doing testing for like 3 months from when he came into the trial.
They do it. It's 7 weeks is the trial. That's what he'll get it June 3rd.
7 weeks. Yeah. Okay.
7
7
weeks,
weeks into the trial. Okay.
Yeah.
That's not
All
bad.
right. Thank you,
Thank you.
Lisa
Thank
and
you.
Frank. We're going to
Thank
move
you.
Thank
move
you.
on to Barry. Go ahead, Barry.
Hey, good evening, guys.
Good
So I just
evening.
had, what's that?
Good evening.
Good evening, Rick. So my last shot of Lupron, they also gave me the bone strengthener, and so I read the article that AnCan published on it, but I've kind of started developing some dry mouth now, and my tongue seems to be more sensitive to hot and cold and that sort of thing. And I was wondering if this is something that will wear off after the bone strengthener wears off, or what any experience on that might be from the guys. And I
Personally, I
did read
haven't
that
heard of
paper.
that particular side effect from a bone strengthener, but maybe someone else has. We'll have to look that one up, Barry, and see what the incidence is.
I haven't either. Which particular drug are you on? I'll do it while we're talking.
Okay.
Lupron, and then I think they gave me a bone strengthener, denosumab or
Okay.
denosumab or something.
Denosumab.
Denosumab.
Zofigo.
And AnCan had a PDF file on periodontal issues and all that sort of thing. I read that.
Oh my gosh, yes. That was done
Oh.
by Dr. What was his name? The dentist in Philadelphia.
Yeah, yeah, when we had that
Oh,
guy.
Dr. Bob?
Dr.
Yeah,
Bob.
Dr. Bob.
Yes. Oh, he
That's
must
a whole
he-
different story than just dry mouth.
Yeah.
Although he did, I think, list dry mouth and recommended sucking on ice, drinking lots of water.
Okay.
They had all kinds of spray products and avoid.
Well, that was from
mouthwashes.
chemo, though, Barry. That was from chemo. That was not from. I don't think that was from denosumab. We'd have to go back and look, but that was all of that stuff with the sucking on ice and everything else had to do with side effects from docetaxel. Did you have any of those side effects from your docetaxel?
No, but he listed that bone medication.
He did. Okay. Well,
in the PDF.
We defer to him in memoriam, I guess. But that's very interesting. I mean, I can tell you, I've not heard of those side effects from either zoledronic acid or denosumab. But that doesn't mean that we don't have experience. I mean, there are many of you who have been on bone strengtheners in this group. Has anybody else ever had any salivary or dry mouth issues from being on a bone strengthener that you can associate with the bone strengthener?
Not me.
I have lots of dry mouth, but I can't tie it to anything. This is mostly in the evening when I sleep, and I think it's more related to the position I'm sleeping in, and my mouth opens up and I try out.
But not during the day. Are you on a bone strengthener, Dennis?
Yeah, Prolia.
You're on Prolia is a bisphosphonate, correct?
No, it's the lower dose of denosumab. It's
it's the lower dose of denosumab.
Yeah.
Okay.
Monoclonal antibody.
Okay. Well, if any of you guys have any information on this, but I think that if you do have dry mouth, the remedies that Dr. Bob suggested are very solid. That part's good.
Okay.
So do you see anything listed, John, for denosumab in terms of side effects?
No.
No. All right. And we'll take a look also at Dr. Bob's PDF. Go ahead, Len.
Yeah, Barry, are you taking any other medications?
Just Abby, prednisone, and Vanaxolin for hot flashes that Dr. Heath prescribed.
What is that last one?
Venlafaxine.
Venlafaxine.
Oh, venlafaxine.
Yes.
Couldn't that give you dry mouth? Rick, you've been taking that, I think, right?
It doesn't give me dry mouth, but I've been taking it a long time.
Yeah.
I think it's that's the culprit.
You think it's the venlafaxine, Dr. Bob? Sorry, Dr. John?
I think so.
Okay. Yeah. I think it might be the venlafaxine. You might want to talk to them, especially because it's Mayo, about oxybutynin if you're a candidate.
Okay.
Because Stish just published his paper, just finally got his paper published after a long time. And he was the guy originally who suggested using oxybutynin for hot flashes. It really came out of Mayo. So I'll put the drug in there, and I'll put a reference to the paper in there. But there are some people who are not good candidates for oxybutynin. Isn't that correct, Len?
Yes. Well, my recollection is that long-term use can cause cognitive deficit.
Okay.
Yeah.
So here's the drug. I want the drug. And what's the other name for oxybutynin? The trade name?
Ditropan.
Say it again, Dr. John.
Ditropan.
Ditropan, right? Ditropan. So there it is. I just put it in the chat, and I will look for the Stish paper, which I think just got published somewhere very recently.
Okay, thank you.
All right, Barry, we're going to move on, if it's okay with you, to Matt McKinn.
Hey, I've got a couple of comments on these drugs from
Go ahead,
Mayo, directly from Mayo. One of the Mayo doctors posted a slide about what drugs to take for hot flashes. And venlafaxine is listed as acute toxicity, nausea, decreased appetite, dry mouth, insomnia, and withdrawal requires careful dose escalation and tapering. Also, on oxybutynin can cause dry mouth, constipation, and urinary retention, particularly in the elderly and at high daily dose, greater than 15 milligrams. Just a couple of comments by Mayo doctors.
Okay, so there's your likely culprit, Barry. It's probably the venlafaxine.
Thanks, Jeff and guys. I appreciate that.
Jeff, they're saying that both oxybutynin and venlafaxine can cause dry mouth?
Yes, they are. The specific, I mean, they've got about 7 drugs listed, and both of them say, oxybutynin specifically right away says can cause dry mouth, constipation, urinary retention. Venlafaxine, on the other hand, says acute toxicity, nausea, decreased appetite, dry mouth, insomnia, and withdrawal requires careful dose escalation and tapering.
Okay, and I found the article on the oxybutynin, and there's also a commentary from Dr. Alicia here, and I'm going to put them both in the chat window. So are you using
Danny Langford just confirmed dry mouth with venlafaxine also. Yeah, are you taking oxybutynin, Barry?
Oh, just venlafaxine.
Yeah, there you go. All right. I think we solved your case.
So
Yeah.
what about,
I'm
have
done
you
with that.
tried using a what? Have you tried using the Ember Watch, Barry?
No, I haven't yet.
I would say try the
I have
Ember
one for
Watch.
sale. I have one for sale.
Oh, you have one for sale. It didn't work for you?
It
Okay.
didn't work for me. It's like 2 weeks
Okay.
old.
Yeah. Barry, get hold of Danny.
It's brand new. It's 2 weeks old and it didn't work for me. So if you want
And
it,
it
I'll
didn't
sell it to you.
work. So, but you can return it within 30 days, Danny.
I think I just missed the cutoff, so I thought
Oh,
I'd sell
okay.
it.
Hey, you guys are pretty close. You're both in well, no, wait, I don't know if you're pretty close. I think you might be pretty close. Maybe you could even meet up to do a handoff. But connect with each other. Send each other a message, okay?
Okay.
So that I don't have to connect you afterwards. And if it doesn't work, reach out to me. But connect with each other. Maybe we made you maybe we got you a great deal here, Mr. Blomquist.
Sure, I'll check it out. Thank you.
Danny,
Mayo
I think the guarantee is 60 days on
Yes,
the.
it is. It
yeah.
is.
Okay.
This
Okay.
Mayo doctor recommends 2 different drugs as appropriate first-line agent for most patients. One of them is citalopram, and the other one is escitalopram, ESCIALOPRAM. They say both of them are appropriate for first-line agents for most patients. I could put those names in the chat. But
It's basically the same drug. The escitalopram is just an enantiomer of the other one.
Okay.
Okay. Jan, you go ahead.
I just had the question, what dose of venlafaxine are you taking?
I think it's 30 milligrams.
That's
30.
the.
Danny says his is
No,
37.
37.5 is the lowest dose. So
I was just going to say 37.5 is the lowest dose. I was just going to say
Okay.
that. It's
Well, I think that's what
37.5
it is.
for me.
That's what she's
okay.
studying on.
Well, if it's the
Now-
lowest dose, then
Here's another
I'm not
thought.
convinced it's the venlafaxine, but that's a whole different story if you're taking 37.5.
You know, the other thing is you could try taking that 37.5 on extended release because it's available on extended release. And that
Okay.
might make a difference.
Dr. Jack, go ahead.
Okay, thank you.
Yeah, I'm confused. I mean, I thought oxybutynin is an anticholinergic drug used for spastic bladder to relax the bladder. And now I'm
Right.
hearing about hot flashes. I'm totally confused.
Yeah, it's because Mayo Stish, Brad Stish at Mayo, a few years ago, and I just put the reference. It's right there in the chat window for you. Has been using it. Originally, they set the trial up with abiraterone. So the word went out, it's only good with abiraterone, but that's not the case. As it turns out, it works with any of the ARPIs. And I'm just about to put in Alicia Morgan's editorial on that, which is called Old Dog, New Tricks, because just for the reason you're saying, Dr. Jack, and I will put that in right now, and you can read both those articles and it will bring you up to date.
Thank you, sir.
Okay, Matt, we didn't get to you yet, did we, Matt?
No.
Okay, go ahead. Just chance.
Hey guys, evening. First thing, just real quick, I want to thank Rick and the team for recommending the Real Recovery. I just got back from the California, Nevada one last weekend.
All right.
Okay.
Pictures. We need pictures.
I'll send you a picture.
Send us a picture.
Catch anything?
Oh, I caught so many. It was insane.
Really? Wow.
Yeah. I probably had over 20 trout on the line and 3 in hand.
Oh my gosh. Did you ask if you could take them back to the zoo?
No, these were catch and release. That's why there was so few in hand, I think.
Okay, tell the guys, in case anybody doesn't know what we're talking about, please tell the guys what we're talking about, Matt.
There's a nonprofit organization called Real Recovery, spelled REEL. Basically just connects any males with cancer of any kind can apply, and they hold retreats all over the country that are basically completely covered with the exception of transportation. And generally in beautiful places with great guys. There's a lot of coordinators helping, and there's a social worker facilitator. So it's kind of a combo of guys talking it out and guys going fishing. And it was great. It was great.
That's it. Where did you go?
Hoolywell Dude Ranch, south of Bridgeport, California, in the middle of nowhere.
Okay.
Yeah, it was great. So thanks for the recommendation. A question. So, I've talked about this on this meeting probably twice now. I just passed my 24 months of ADT, right? I was oligometastatic. I had the SBRT at the prostate and the Mets. Key factor is actually met with Dr. Harstark today, and I forgot to talk about this, so I emailed her. But I was looking some stuff up while I was talking to you guys. So for whatever reason, my lymph nodes in my pelvic area were positive on the PMSA PET scan, were not treated during radiation. You know, that ship sailed. It was a while ago. Independent of that, my response has been really strong. My PSA has been undetectable for quite some time. It went from 18 to undetectable pretty quickly. Overall, I'm doing pretty good. I've been kicking around going on even though I'm, metastatic, on a treatment break, right? Holiday or whatever. Dr. Harstark's supportive, kind of either direction. For some reason today we forgot to talk about those lymph nodes. I was doing a lot of research after this meeting started. Any thoughts from you guys on, kind of like taking an ADT holiday when the lymph nodes in the area are known to be, prostate cancer positive but not treated? Or maybe the question goes in a different direction. Has anyone had radiation based on past images? A PMSA right now wouldn't show anything in those lymph nodes because the ADT is working. But I guess there's a theory I might feel better if I could get them radiated and then take a break. So that's a kind of a broad question. If anybody has any quick hits on it, that'd be appreciated. Otherwise, I'll talk to Dr. Harstark about it.
Well, go ahead. Anybody else want to go ahead, John? You go first.
I think that imaging before deciding, re-imaging before deciding would be a good idea. Even though you're still non-detectable, the imaging might not produce anything, but if there's anything hot on the imaging, then it might be too risky to take a break. But if there's nothing hot on the imaging, I think it's time. You're kind of a little bit like me, except for I didn't have bones. Mets. I had lymph node mets, and I went 2 years, or 2.25 years. I was non-detectable, and I went off all medications and got 4 more years of being non-detectable.
Nice.
And my guy got a PET scan just before taking me off, and nothing was lit up. So we know that there were lymph nodes that didn't get specifically treated by your radiation therapy, but that doesn't mean there's active disease there. What did you get for radiation treatment? EBRT to the what did you get for RT?
SBRT, 5 killer sessions to the whole prostate plus a little space around it, and to all the bone mets individually. Scapula and shoulder blade.
So you had some lymph nodes that lit up on a PET scan way at the very beginning
Yeah,
the
on my original
journey.
metastatic diagnosis on the PMSA.
The SBRT did not aim at them, and you did not get EBRT, right?
Correct.
To the whole pelvis. Well, that's an interesting situation. Yeah.
Yeah, it's kind of a regretful one. I think if I'd have not been in such medical crisis at the time, I would have understood what's happening and maybe
Well,
advocate for
I
it.
don't know. See what the other guys think about re-imaging, and then if there's anything active it's not too late to get SBRT to an active
Well, not
lymph node.
SBRT.
I mean, it's not too late to get those metastasis-directed therapy to those nodes that might save you being on Lupron for a while. I mean, your bones are thinning. You should have a break if you can.
Just wondering about do the PMSA imaging show, anything? I know sometimes it can. I've learned in this meeting, but for the, I think for the higher percentage of folks, my undetectable PSA, there'd be value of that imaging.
Yeah, but I think the point here is that if those nodes are still alive, then they're going to show up on the PSMA scan, even though they're not causing PSA. So, there's a difference between looking for the metastases that you have when we know you have metastases versus trying to find out where the metastases are when we don't know where they are and we know you need a higher PSA. The situation with you is we know you have them. Are they still there? And we could do a PSMA scan, and I absolutely agree with Dr. John. The other thing I want to say is don't beat yourself up about not either shooting them or not doing the extra IMRT. And yes, right now you would, they might be able to shoot them with, if they're there with SBRT, but for some reason, which I never have properly understood, when they have a metastatic man or when they debulk, for some people they debulk after chemo, they don't do this extended field with IMRT if you are metastatic. And I don't get why, because I still think it would be valuable, but they sort of avoid it, which is very, very frustrating. So even at the time, we would have had a tough time justifying to them. Maybe we could have convinced Dr. Andrea, I don't know, but you're not alone in not getting that extended field taken care of early on, Matt.
Okay. Yeah, I imagine it's an area of further study moving forward. I know kind of this oligo, low volume, high volume is always halfway between one study and another. Okay, so I'll talk to her about that. Talk to her about re-imaging. Len?
Yeah, I was going to say, maybe the concern with radiating the whole pelvic region could be that it might take a toll on your bone marrow. But anyway, RJ, you go ahead.
Yeah, I was just going to add that the other thing when you're on a holiday, like the PSA, if it doesn't come back, that's great. If it does come back, then you can also get another PSMA because that's indicative that you have active cancer that's producing PSA, and at that point, if there's cancer there, like they can actually have a new image and confirm that, and then you could just get that treated. Then, I just last week I talked to my radiation oncologist, and he said, well, if you want to do a holiday, then one thing is if the cancer, like if you have particularly, he was convinced that all of the metastases I had he treated and there's no cancer there, but there's new metastases that show up either, 6 months into the holiday or 6 years, that they can go back and they can treat that, which can prolong your holiday, and or you can decide to go back on the ADT and get it treated, and then you get the double whammy, which is what most people get on the initial SBRT and the IMRT, where you have the hormone therapy, which weakens the cancer, and then the radiation does its thing to the cancer. So like there's multiple things that you can do, but maybe the first thing to do is just to get a scan and see if they can see it. And if they don't see it then, maybe they'll see it later, and maybe it's gone.
Yeah, no, thank you for that. I kind of thought about that as well, right? That's part of taking a break, is kind of like, waiting for it to come and then whack it in a couple different ways. And, I thought from my line of questioning is, if possible, I'd almost like to avoid that, right? I've got the cancer like really ducked down in the foxhole right now, hiding. And I don't like letting it stick its head up to know where to shoot if I don't have to. But no, this has all been very helpful. Thank you.
But you got to think about your heart and your bones.
All right, what was that, guys?
I talked on top of you, Len. I was just going to say, you want to keep the cancer in hiding, but you got to think of your heart and your bones in the long run too.
Yeah. No, that's why she's definitely said it's my choice. She wants me to live a long time as well.
Sorry, Len. What were you going to say?
No, that's fine, John. I was just, I think I said to Matt that looks like you've already answered your own question. It didn't sound to me like you were comfortable taking a drug holiday, so you shouldn't do it.
That's kind of where I was at.
Yeah, but John is right too. You got to be concerned about being on the hormonal treatment for too long, and you get all the side effects that come with that. So,
yeah, I mean, it's a good issue. I mean, there are other things that you could try doing though. I mean, one of the things to talk to Dr. Andrea about is maybe going on monotherapy. You're on Abby, right?
Abby, and I'm on the lowest prednisone possible, 2.5.
The lowest prednisone. Maybe a couple of things. Maybe one of the things to talk about is try going on daro. Try going on monotherapy daro. Talk to her about going on monotherapy daro, letting some testosterone come back, protecting yourself with the darolutamide, see how you do with that for a while. Because that not only keeps the cancer off balance, because you're changing things, but should make you feel a little bit better, and also satisfy your own psyche that you're still doing something.
Yeah, sounds like I should have logged in last week before today's meeting with my doctor. I'll email her.
Well, that. That's always true. You know that. Well, you could have reached out to me.
Maybe monodaro would produce a little estradiol and help those bones.
Yeah. It's all worth discussion. Yeah, I was too busy to join last week. I was ripping trout.
Okay, that's a good excuse. But I think last week was a good one. We might have even talked about monotherapy, Daro. I can't remember last week. So, go back in and put in monotherapy darolutamide in the search and see what comes up for you on that. And yeah, and tell Dr. Andrea that there's a bunch of guys doing well on monotherapy daro, and we know the doctor who is prescribing it if she would want to talk to any of them, and we'd be happy to connect her.
Yeah, this all sounds good. I got a good direction now. Thanks, guys.
Okay, thank you. Jim McPhee, you are up.
And John, would you just highlight your comment in the chat window too before you get into what you want to talk about, please?
Oh, about the
oxybutynin.
Yeah, the oxybutynin. Sorry. Yeah, I'm on 2.5 milligrams of oxybutynin once a day, and I still get warm. Coffee is a trigger, and I'm not willing to give up coffee, but I understand that. And if I have something, it's getting warm here now in Ontario finally, but up to now, it's been cold. And if I have a scarf or something around my neck, that triggers a hot flash or a warm spell. But that feeling of intense burning inside, I guess, that characterized the hot flash, it seems to have taken that away. It's not like the good old days when I had testosterone and didn't worry about it, but it's a lot better than don't wake up at night burning, I guess.
And dry mouth? Any dry mouth?
No.
Okay.
Well, if I sleep with my mouth open, yeah, it's dry. And so, so
Yeah.
the trick is just to sleep with my mouth shut, and I'm okay.
Well, that could be a solution for Barry. Barry, maybe you just want to get some Scotch tape and see if that helps.
Yeah, I'm willing to give that a go.
My wife snores a little bit, and she was trying transport tape that the hospital uses for putting on bandages and stuff like that. Eventually it caused her problems because of this tape being on her mouth all the time, but with her mouth taped shut, the snoring dropped dramatically. So it is something you might want to try if that's and then it once the body learns to keep its mouth shut at night, it tends to stick for a while. It's a bonus. Oh, I just got my a final laboratory genetics report, and they tested 19 genes and came up negative. So, you can. I don't know what you do with that. I guess it's just it doesn't tell you anything.
So was this germline? Was this for germline, John?
Where they take the blood test?
What were they testing for, germline or somatic?
I don't know. Hereditary breast, ovarian, prostate cancer. Panel.
Okay, that's germline. If it was hereditary, that's germline.
And they tested 19 of them, and the result was negative. So.
Okay.
All right, John, anything else?
No, other than I'm coming up to my 3 month shot of Zoladex, and I'm doing really well. I'm absolutely surprised. If this is the way life is going to be, I'm okay with it.
Okay, we're okay with that too.
Yeah.
Now we've got David Fisher and Muslin, which is going to be a joint discussion, maybe even with Rick. I don't know. Who wants to start off here?
I think you're the best talker around.
Okay, I'll set the scene, okay, and then you guys can discuss. And there's also a couple of things that I asked David Fisher to bring out because I think it's going to be helpful for all of us here. Situation is that both Davids have recurrence, but their recurrence is a little bit different in that for David Fisher, it's the first time in 15 years, 16 years that his disease has come back. And over the last 4 or 5 years, he's had a very, very slowly creeping PSA that's gotten him up to about 0.5 0.4, 0.5, but somewhere in that area. David Muslin has known metastases, but he's managed them with monotherapy darolutamide most recently, very successfully, going on and going off and going on. And he's done spot radiation in the past, but his metastasis is also creeping up. Both of them are looking at the same two trials. One is the Andromeda trial with Dr. Kishan at UCLA, which offers spot radiation to the known metastasis. Both of them have metastasis that we can see on PSMA scans. And Kishan offers either Pluvicto, 2 doses, or 1 dose of actinium, and he's randomizing between those two. So really what we're looking at is systemic therapy through the radioligand therapy, no hormone therapy. The other trial is called PSMA DC, which is being offered at around 140 locations. The Kishan's trial Andromeda is only being offered at UCLA, but this other one is being offered in many places. It's sponsored by Novartis. And in that trial, it is, again, spot radiation to the metastases, wherever they are. They have to be less than 4, I think, or 5. And up to, and this is what it says, up to 4 sessions of Pluvicto. So they're very, very similar. And we're trying to get both of them into one of those trials. So that's the background. And maybe David, you can sort of fill in where we're having issues. I will, one other thing, which is in both the trials, they're kind of similar to the long game trial in that if we see the metastasis on a technetium-99 scan, then you're not eligible. But if it only shows up on a PSMA scan, you're okay. So.
Okay. Well, should I start off with Dr. Kishan at UCLA?
Go ahead. And, you know, your thoughts, where you are on those two.
Well, he's a very nice man, and I have direct emails with him, and he'd like me to be in the trial, but UCLA won't allow it. It's the most wacky thing. I have an Advantage plan, and they're willing to cover it. I have a letter of authorization, but UCLA has this is just to warn you guys if you ever get your hopes up. They have a policy of no out-of-network patients. And I have banged my head against the wall and talked to heads of department. Rick's even got some woman who's head of radiology or radiation therapy, I forget what. There's no way of getting through. Willing to pay for it, they won't take me. That's number one. Even though I have an email from Kishan saying, you're perfect, I'd like you in this. The second one, which I discussed with Agarwal just today at UCSF, is the one that Rick referred to that's Novartis. It's 142 different locations throughout the world. But like he says, it gets tricky because of the 2 types of scans. You can't show up on the TC99 or T99, the older one, the bone scan. Just yeah. So I've had both scans, and you'd have to be almost a magician, to find the detective, to find the lesion on the older scan, and they won't take you if it shows up there. And they have, if I can give you guys, I can put up the name and the website for this trial. They have 2 radiologists look at your stuff. They don't tip off either one of them as to what the other test was, the other scan, and that's how they eliminate you. But even though mine sort of shows up, Agarwal says, I think I can get you in there. So, but it's such a tricky game. And what bothers me about it, I'm sure 2 years from now, this will be a slam dunk, but it isn't now. Other thing I asked Agarwal today, struck me, trying to avoid ADT, right? So I have one tiny lesion on my 3rd lumbar. And I said, so my PSA has been holding at like 0.3, 0.4 for the last 4 or 5 months. So I said, so what if I just skipped he wanted 6 months now of ADT followed by 25 radiation treatments. I said, what if I just skip that? He says, you can do that. There's probably no harm in that. You know, you can take the chance. And he was quite supportive. He says, you're 75, you got AFib, go for it. Let's do it without. So that's my other. I was shocked that the guy would be that open to foregoing the ADT.
And Dave, did he get back to you on how many sessions of
No, he hasn't yet.
He hasn't yet. Okay.
No, not yet. Yeah, it's up to 4 sessions of Pluvicto or whatever it is.
Right.
Yeah.
Mr. Muslin, what's
yeah.
No real updates here. I sent Schmulowitz a note last night asking about the PMSA DC scan, that I really thought that I do qualify for it, and could you let me know? And also, do you have to do 4 cycles? Can you just do 2 cycles? So I'm waiting for him to come back, and I reached out to that woman that David Fisher was talking to, and she was supposed to call back and didn't hear back from her today. So that's my update, which isn't a lot.
So have you talked to the people at UCSF? Is that the one you're talking about?
No,
yeah.
UCSF.
Yeah.
No, David's talking.
UCLA. They're doing this, the trial at UCLA, right, Rick?
Yeah.
Yeah, you might consider the one at UCSF. I think they're more lenient.
Well, David can do that trial at University of Chicago.
Right. You can do it anywhere. It's like all over the world, 142 locations.
Yeah. It's crazy. They're doing that trial all over the world.
Yeah.
Yeah, so David's options are to do the PSMA DC in Chicago or to go to UCLA. And he reached out to try and check the insurance. But what I want you guys here to think about is that, you know, trials are great, but there are so many ins and outs. And one of the things we don't often think about, because we think, oh, yeah, it's a trial, everything gets paid. No, everything doesn't always get paid. And you have to clear those trials with your insurance company. And that sometimes there can be issues with the provider, as with Dave and UCLA. There can be issues with your payer, they won't pay for trials. So I just want everybody to be aware of these issues if they're thinking of trials. It's complicated. It's complicated, and Dave Muslin is going back and forth with Dr. Schmulowitz because Dr. Schmulowitz doesn't think he's even eligible for PSMA DC, but we beg to differ, right, Muslin?
I read sentence by sentence yesterday, and I sent him a nice email. I think I sent you a copy of it, but we'll see what happens.
Let's get a voice from Dr. Jack. Go ahead.
I'd like to get some information because I'm not aware. David Fisher, you sound very much like my case. And 15 years out, you got a reoccurrence, slow indolent growing, landing on your lumbar vertebrae. You know, that's kind of what happened to me. And then it took 5 years for them to figure out where it was. So
why is that?
What?
Why did it take 5 years?
Oh, that's me, not you. But I'm just trying to understand. You have atrial fib. You don't want to have androgen deprivation. It screwed me up for sure, and I can't blame you. Now, what is your goal? Your objective is to get the Pluvicto in lieu of spot radiation because you believe it's going to create a cure rather than just, you know, a suppression.
I'm just taking it down the road. I mean, how many years we got left? That's how I look at it, right? So.
Well, you know, you're only 75, I'm 87. So, you know, you may have more. Okay. And it's very, very, very realistic. And so don't bury yourself yet. But let me ask you a question. Why are you going for the Pluvicto you're hoping to achieve?
Okay, Jack, just for a correction, the Pluvicto is in lieu of the hormone therapy. He gets the spot radiation either way on the lesion.
I get it, but why do you need it through a trial? Why don't you just buy the Pluvicto?
Oh, is that? I didn't know it was. I'm serious. I didn't know it was for sale. At my level of. Yeah.
It used to be that way. I think there are people now that are getting it who, you know, can get it before they've had docetaxel, cabazitaxel, and all the other things. You don't have to go through triplet therapy to get Pluvicto anymore.
Oh, and because is it approved at your stage or at my stage as a therapy? I didn't know it was.
From what I've heard, it was, but ask Rick. He knows more about that than I do. I just heard.
What does he know?
Through what does he know? Through the grapevine.
Okay. So it's available to David Muslin. And approved for David Muslin. It's not approved for Fisher because he's never done any type of hormone therapy.
I see.
So there are people that might give it to him. I mean, it's probably the cost is going to be around $25,000.
There goes the RV.
So we haven't discussed that. We haven't
20 or 25,000 total, or is that monthly?
Total because he'd only get one application. He might get two, then it would be 40 to 50,000. But if he was trying to put it together, or he could go overseas and get it done for somewhere in that region, maybe even less. Down in Mexico, there's a place there are a couple of places down there that will do it.
Germany does it too.
You know, I asked Schmooze if he would do it, and he declined.
How come?
I don't know. Any ideas, Glenn, why he wouldn't do it?
Well, he said to you, what he said to you from what you told me was that he doesn't know how many it would take to go with, and what does he need? You need one, you need two, you need four. I don't know.
That's exactly what he said. You're right.
So, but David could get it. David has had enough treatment that he could be eligible and just get one or two, get approved for Pluvicto, get one or two, and then keep the others in his back pocket. God forbid he needs them later on. You got some more hands up, Len.
Yeah, let's hear from Neil Sundstrom and then Gary P.
Thanks. So how long do these trials go? And the reason I ask is because I'm kind of in the situation these guys are in that, you know, I had my prostate out in 14 years ago. came back 3 years ago. I had radiation and ADT, and I stopped the ADT, and it's hovering around 0.05, somewhere in there, my PSA. So it's back, but I haven't had a PSMA scan for a couple of years, and so I guess my question is, I'm going to see Agrawal tomorrow, as it turns out, and so I'll talk to him about this. But I'm not sure how long these things go. I'm going to ask him, maybe it's an opportunity to get another PSMA. It's been a couple of years, and if something shows up, then I may be eligible. But is there a start and a stop to this? That's this particular Novartis one?
Goes forever. I'll look at it right now. It's in front of me. It's like 6 years or something crazy.
Oh, okay.
Yeah,
Okay.
study duration is 6.5 years.
Okay, so if I get a PSMA, which I'm probably due for, every couple of years, I guess, then if something lights up, then I might be eligible. If something doesn't light up, then I won't be. So, okay, thanks. I'll talk to him tomorrow.
Yeah, nice guy.
Okay, thank you, Neil. Gary P., go ahead.
I was confused by the comments about the fact that insurance had agreed or not agreed to pay for participation in these trials. But don't most trials come without cost to the patient?
No, that's exactly why I wanted to raise this. This is the common misperception. Most trials will come without cost for the treatment that they're offering in that trial. So both David's case, the Pluvicto may have no cost. Or the alpha, the actinium-225, the alpha molecule may have no cost. Most everything else is going to have a cost. They're probably charged for the spot radiation. And they would charge for any other incidental costs that come along the way. And this is why, if you're going for a trial, you have to always ask the trial coordinator, what am I paying? Will I be paying for, and what won't I be paying for? And you have to go to your insurance and say, will you cover me in a clinical trial? Which they may or may not. Some do, some don't. But that's exactly why I wanted to raise this. So don't just assume that because it's a clinical trial, that the trial is covering all the costs. Dr. Alfredo, you just put your hand up.
Yeah, I just want to underline what you just said, Rick, and add one more sentence on top of it. If you develop a complication from the trial, now potentially there's a big debate over who's going to cover it. Oh, whose fault was that? Oh, is it covered by the study? No, it's a separate illness. Oh, it's covered by your regular insurance. So I'm not trying to say never enroll in any study. I just want to emphasize what Rick is saying is you need to get a lot of information before you do. That's all.
What about side effects from the medication? You're suffering from side effects and you're hospitalized.
It depends where you're hospitalized. If they hospitalize you at the place where they're doing the trial, and that's out of your network, you're gonna have a problem. And we've seen that happen. Or you have to call the insurance before and say, will you cover? And then you get into the situation that Alfredo raises.
Right. So the right thing is to ask that question before you enroll in the study, and balance everything out as best you can, and talk to your regular doctors about how they would balance it out. And so sometimes the right answer is, yeah, enroll in a study. Sometimes the answer is, you know what, I'm going to let them do that study in Norway or some other place and learn about the results. I just want to underline what Rick was saying by saying it's not so simple. That's all.
And the issue is that a lot of people think like Gary, and understandably, it's not a criticism at all, because they don't explain it. And you have all these docs say, "Oh, we want you to do clinical trials, and clinical trials are so expensive." And they never say to you, "But you've got to think about this, and you've got to think about that, and you've got to think about the other." They don't. And as an advocate, it concerns us at AnCan. By the way, I just put for Neil, both PSMA DC trial and the Andromeda trial. I put the links in the chat.
Thank you.
So, David, you said you were accepted, or you would be accepted into the PSMA DC trial, David Muslin?
I'm waiting for a confirmation from Dr. Russell Schmulitz on that.
Yeah, so I'm just wondering, I'm just trying to think what I would do in that situation. I mean, I'm sure you have an inclination to go either just observation or to go with the Pluvicto, in which case, why bother going through the trial? Just, pick one and pick one treatment, and you're not committed to the trial.
Right, that's true. But I would have to, if I'd have to do that on my own and probably my own expense, which I'm happy to do. But let's see what happens with these trials. You either get the beta or you get the alpha, one or the other. It's plus the SBRT.
That's the Andromeda trial. That's
I'm talking about the DC trial, where you either get observation or Pluvicto, I think, right, Vic? Wasn't it?
No, I think what I read, everybody gets 4 cycles, up to 4 cycles. And then I read something else where it looks like you have to take 4 cycles, but I'm not sure. But everybody gets the 4 cycles.
Okay.
What does it mean? What do you mean have to take it? What happens if you just say no and drop out? Do you responsible to pay for what you received before?
You can always do that, because you can always leave a trial. So if you keep your mouth shut and you get accepted to PSMA DC, and it turns out that it's a requisite protocol that everybody has to do 4 treatments, and you say, "Okay, I'm dropping out after 2." You could do that. This is why we're trying to find out, what does it mean because in the trial language, it says up to 4 cycles, and neither of the Davids really understand what that means, but we're trying to find out.
Yeah.
What kind of a randomized trial has observation as a choice? I mean, are they where they're getting just observation, or is it a sham infusion?
It's a I'm trying to remember. I want to say that it's a sham infusion, but I'm not sure. Click on the trial and take a look, Jack. Right. Check the trial. I put both the trials in the chat window, so you can look at them. That's not the one I want.
Yeah, let us know what you see there, Jack. I'm curious myself.
I've got the trial. I've got the trial up right here. Just study plan. In the control arm, the study plan is you just get you get randomized between the getting Pluvicto and not getting Pluvicto. And in the control arm, it's watching you after you've just had the SBRT to the metastatic lesion. Am I making sense to you, Jack?
So everyone gets the SBRT, and the others either get observation or Pluvicto.
That's correct.
Yeah, okay. All right. Still got a bunch of guys to get through here. Dr. John, you want to go ahead?
I was going to ask a question about the PATHAC study, but let's make sure we get through all the guys first, okay?
Okay. Robert, would you like to go next?
Okay. Yeah, I saw my oncologist, let's see, 2 weeks ago, and we're doing monotherapy darolutamide. And that's the update. My PSA had gone up to 9.32, and nothing major was found on the PET scans. I'll have another scan in, I think, 4 months, and we'll go from there.
And Robert, what were you taking before you took the daro monotherapy?
I was on a treatment holiday.
Oh, okay.
Before
For
that,
how long?
That one was 12 months. Before that, I was on, let's see, I think it was Orgovix and Xtandi. And then before that, it was apalutamide and enzalutamide and Orgovix and radiation. That was my only met. That was.
Okay, and so each time you stopped one of those drug regimens, you were still responding, but you just took a holiday.
Yes. Yeah.
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 So you're still
and then,
home on
and then over the course of about a year, it goes pretty high. It goes up to 9 or 10, and then we start a new treatment.
Yeah. Okay.
And what's the conversation been with our friends in Bethesda, Maryland?
She's fine with this. I'll go back and see her for the next scan. And then if I have to continue treatment over 6 months, then that leg of the trial's over. So,
okay.
Or I'm over.
Okay. Well, monodaro is a good option, Robert, as you know, from all the guys that are doing it here and comfortable with it here. And it also sounds like Dr. Abel is very, very accommodating when you need to get treatment.
Only for 6 months.
Only for, well, that's okay. It's a good start. You know,
yes, exactly.
When they say only for 6 months, it reminds me, it's the old phrase, David Muslin will like this. Now we're just negotiating, right? So
that's it. Thank you, guys.
Okay.
If anybody has any input.
David in Seattle.
Hi. So last week, thanks to AnCan and Rick, I went to see Dr. Estacio, Dr. E,
right.
at OHSU in Portland. And so my concern was that I have several lymph nodes that are metastasized, and I'm on single therapy with Orgovix, and I was concerned that maybe that's not enough. She assured me that the hormone therapy now is working well. She says your body's fighting it well. There's no need to add anything else, but she wants to be careful. So she's ordered some scans. There's a PET MRI head to thigh scan. She's ordered a liquid biopsy, blood panel, and she wants to look at all that before saying whether or not we add anything like darolutamide or possibly even taking a vacation. I have not had the scan yet. Still waiting to get that scheduled. One interesting thing she told me was that where she practices in Texas, she says they tell the insurance companies what they're going to cover. Up here in Washington and Oregon, she said that's a little bit more of a challenge, that sometimes there are a lot more hoops to go through to get procedures and scans covered. So a couple other quick things for my hot flashes. She suggested Good Patch. There's a patch that I just got from Amazon called Good Patch. You put it on your, or someplace where there's veins. So I'm assuming inside of my wrist. I haven't heard anybody else talk about that yet. I'm about to try it.
Is that an estradiol patch? Do you know what's in it?
No, I think it's hemp based.
Hemp?
Yes, as in cannabis. It may have
Yeah,
some
yeah.
cannabinoids in it. I don't know for sure.
Okay.
Yeah, I can confirm it is a hemp product. Yeah, that's right.
Okay. You know,
Has it been working? Have you tried it?
it's a question for you, Alfredo.
Oh, no. I just know patients who have tried it, kind of mixed results. I don't want to conclude one way or the other, but I know for sure it's a hemp. It's marketed as hemp, plant-based, totally natural, quote, not a drug. So it's fun. It makes me laugh because so many of the drugs that we all use every day are actually derived from plants and have historically been derived from plants. So nowadays we talk about it. Oh, plant-based. Oh, that's really novel. Didn't come out of a test tube. Well, yeah, it came from a plant through a test tube into the pill. But anyway, so all I know is it's based. I wouldn't say no, it doesn't work. I wouldn't say yes, it definitely works. I think you're going to let us all know next week or the week after.
I will update you. The other interesting thing she said, and then I'll close it out, was that with her new practice here at OHSU in Portland, she's observed that clinically our practices, or the practices of the oncologists up here, are significantly behind the rest of the US, and that she's struggling to update those practices to what she would consider current day. And I found that a little interesting, but I don't have the perspective. I've only seen my oncologist at Fred Hutch, and she's got a bit more experience.
David, where are those positive lymph nodes? Are they all in the pelvic region?
No, I've got one in my neck, one subclavic in the nerve bundle under my clavicle, and then one close to my heart.
Well, I'd like to know what the guys think here. If it were me, I'd say give me the daro, or some second hormonal blocker for if I've had extra pelvic lymph nodes. Anybody want to comment on that? Would you all be comfortable with just OrgoVix?
Well, this is exactly the reason why we thought that David should see another oncologist. He was seeing Heather Chang, who's very, very good, but he was nervous that she was undertreating him. So we managed to get him to Dr. E, and I will reserve my view until these tests are done and I hear what she says, because she doesn't overtreat. And one of the things, again, and you've heard it before, is that maybe the way to go for you is a monotherapy ARSI, like monotherapy daro, or one of the other ones. But I think that you're with a doctor who would be willing to do that. She's not married to doublet. She'll prescribe monotherapy if monotherapy is right. And that's one of the reasons we wanted to go. I mean, my answer is yes, especially given that David has P10, which is an issue. We got to think about it, which certainly Dr. E is taking into consideration. And let's see where she comes out then. Probably if it were me, I'd want to be at least for a while longer on a monotherapy ARSI, but we'll see what she says. John, Dr. John, what do you say?
I would feel more comfortable on the daro mono.
And Robert, you're sort of in there. You're in the trenches with this right now.
Yeah, my question is, initially my insurance company denied mono-daro, and they had to appeal it, and then it was approved. But there's some criteria that they wanted it. The insurance company said it had to be with
Right.
ADT, well,
Right.
or they wouldn't cover it.
Right.
Something like
Right. Right. So that is technically the approval. And so then the docs have to go fight for you for it. I think the only treatment that's approved mono is and Len will correct me, I think is enzalutamide. But
possibly, I'm not even sure it was actually FDA approved, but it's in the EMBARK trial, it certainly did prove to be superior to ADT alone.
Yeah.
Are all
So-
ADTs injections, or do they have
No.
pills?
No, you have pills. Orgovix is a pill.
So couldn't you take Orgovix and darolutamide and just not take the Orgovix and have it approved? Serious.
Yeah, you could.
Yeah, but it's a $3,000 prescription you're throwing out, you know.
You don't throw it out, and if it's being paid for.
Yeah.
You fence it to Larry and
I did bring that up.
Hey, I was on daro for many. I'm on daro for many years, and for a number of years, I was just taking 2 pills a day, not 4. And I probably have 3 or 4 months of daro, which is very expensive, but I'm not ready to sell it yet. Serious. It's good money.
You waiting for the market to go up?
No, in case I ever want to use it, in case I ever want to take it again.
Yeah.
Unfortunately, the market usually goes down in these instances because eventually they come off a patent.
Right. Okay. Gary Martin, you are up next.
Okay. Yeah.
And I'm sorry to interrupt, but there was a case where somebody was unable to get insurance for daro, and I was thinking about giving them some, but I didn't do that. Sorry, that's it. I'm out.
Any of the docs, or if we have lawyers in the group, would that be something that Larry could be prosecuted for? I wonder.
And AnCan does not endorse self-medications.
Not if I'm dead.
Not AnCan. I'm talking about.
Yeah, Larry. Larry,
we want to set that record straight. I'm just
The other Larry will testify it's illegal.
yeah, doing it is one thing. Telling all of us about it is another. So.
All right.
Yeah.
Where were we? Gary, go ahead.
Gary Martin.
Yeah. I'm among the unlucky group that has several of the more aggressive genetic mutations from the somatic biopsy sample. I've got 2 of the TP53s and 3 other mutations, plus a very high tumor mutation burden, 78. And initially with the biopsy, and that we talked about earlier, I've been reading some about what happens if it morphs into the more aggressive small cell or neuroendocrine. There's special biomarkers that can be tracked in the blood, and the FDG, I think, PET scan is better at detecting that kind of resistance. My question is, who are there providers you would recommend that are knowledgeable and up to date on this tracking these more exotic, aggressive forms, and any centers that you would suggest are ahead in that field.
Rick, you familiar with anyone who specializes in neuroendocrine?
Well, yes, I am. But first of all, I want to assure you that you're only, as far as I know, you're only sitting with one of those bad boys, which is TP53.
Right. The T and plus the TMB was high.
And the TMB was high initially, but that was before treatment. So, you know, we have a lot of guys, we have several men in this group who have a single TP53 or a single P10 or I don't know that there's anybody with a single RB1, but I think the only one I would be concerned about is RB1. If you had that alone with the TP53, I don't think you have to be too concerned just yet. And right now, you've only been through one round of treatment. Now, once you've been through multiple rounds of treatment, and we're still finding that those multiple rounds aren't working, then yes, I think, as in Frank's case, we do want to be doing those tests that you mentioned. We want to know, we want to find out, is there any evidence of chromatin? I mean, we've had situations before, and the guys who've been around a longer time in this group are well aware, and especially Len and Dr. John, is that we lost Herbie, who we loved, who was a moderator in this group, Professor Herb, who had a lab at NIH, because the bloody NIH didn't follow up, nor did his doctor at Johns Hopkins. And he had all these symptoms of extreme fatigue, couldn't get out of the chair, and all of this stuff. And when you're at that point, we need to be thinking, well, are you morphing? And we need to be doing these tests for the chromogranin and maybe doing a DLL3 test, or doing a Netscape scan, or all of these things. I don't think you need to be thinking about it right now. On the other hand, you do need to have a lead doc who's on the ball. And didn't you, Gary, didn't you go see Schmulowitz?
Yes, yeah, I consulted him, and he was in favor of the radiation therapy, which I got at Mayo. So right now I'm in good shape, I think. PSA
right, and stick with Schmulowitz, and when things start to happen, he's going to be the guy. But don't, we can get ourselves into an awful mess through Dr. Google, and because we don't understand it well enough. And the other thing that I've been reading, and I'm probably going to get it into the reminder sooner or later, is we can get ourselves into a mess with AI, because a lot of times AI hallucinates on some of this medical stuff.
Right.
It's not reliable.
Hallucinate. Yeah.
And so for you, yes, you have a bunch of mutations. I mean, I'm looking at them right now. The TMB is no longer a factor, but it could be a factor in the future.
Right.
But they didn't choose to give you Keytruda, pembrolizumab, in the first place. Right. TP53, we've got to keep an eye on. RNF, I don't know anything about, but some of the other guys do. CDKN2A, I don't know enough about. And ARID1A, I don't know enough about, but Dr. Schmulowitz does, and he saw that. So we have to rely on that, and don't, sit there thinking, oh, well, I got a bunch of these mutations, I'm going to be in the toilet. No, not true.
So it takes a period of time of multiple rounds of treatment before it begins to morph that way.
Len, respond to that, please.
I'm sorry, Rick, what?
I said you respond to that.
Yeah, I was just going to say, just because you have a mutation doesn't mean it's part of the driver of your cancer.
Okay.
Right?
Okay.
It could just be a mutation that's just sitting there, it's not doing anything. And if you're worried about neuroendocrine, you could just ask your doc to do a simple blood test with chromogranin A, CGA.
Okay.
And if you want to be more secure in that, there's another one called NSE, neuron specific enolase, NSE. Yeah. The third one, synaptophysin, but you know, these are blood tests that they can order, and just to give you peace of mind, I'm sure they'll be within the normal range. And something I should mention for the whole group here, something I mentioned to Rick that I just found out recently myself was, if your CGA, chromogranin A, is elevated, first thing you want to know is, are you taking a PPI, a proton pump inhibitor, or something like pantoprazole? Because I know someone who was on a PPI and his CGA was 1,000, which is really, yeah.
Yeah, I am on. Yeah.
Oh, okay, yeah. So, well, it's a good thing I mentioned that then. So, you know, don't freak out if your CGA comes back high, because this fellow that I'm thinking of, his doctor said that's, I'm not sure how he knows that, but he said that's probably just your PPI.
Yeah. Okay.
You don't have neuroendocrine.
So there's multiple tests that can be run and maybe get a baseline.
Yeah. And a lesion in the liver is a kind of a telltale sign of neuroendocrine.
Okay. All right.
Yeah.
Thank you.
You're welcome. Let's see.
I had something I wanted to ask. Oh, what about your liver?
Liver?
Yeah. Didn't you have some liver inflammation from darolutamide or something?
Yeah, there was on the PSMA, there was a spot, but they didn't think it was cancer initially. I've got an MRI scheduled of the abdomen in early June, so hopefully that'll help clarify that situation.
And you had abnormal liver blood tests too.
Yes, yeah, that was in response to the chemo. It turned out that's resolved.
So that's resolved. Okay, thank you.
Thank you.
So your liver enzymes are normal now or near normal?
Yes. Yeah, they're back to normal.
Okay, good. All right, Gary, thank you. Danny Langford, you're up.
Well, I'll give you an easy one. I don't currently have a urologist. I only have a Dr. Antonarakis, who's a oncologist, and I'm getting a radiation oncologist. And I'm like, do I need a urologist at this point, or do I wait? Because I'm going through chemo right now, and I'm doing the ADT with darolutamide and relugolix. And I'll start radiation in September. But do I need a urologist at this point, or do I just wait?
I don't know the rest of your background, Dan. Do you know his background, Rick?
Yes. Yeah.
Go ahead.
Go ahead, Dr. John. And I mean, I have my view, but you go ahead, Dr. John.
I'm going over the stuff I have in the card here, and I don't see an ongoing need for a urologist for cancer management.
Right.
Okay.
I'd absolutely go ahead, John.
It wasn't me. I think it was Danny.
Danny, I don't think there's a reason for you right now to require a urologist. Certainly not for your cancer management. If you have any issues with respect to the treatment that give rise to urological treatment, then I would speak to Dr. Antonarakis and he'll set you up with somebody.
Okay. Okay. Going through chemo and my, you know, I'm doing symptom management through their e-symptom management thing online, but I'm just burning up all the time. Like I had a reaction to the docetaxel, and they had to stop it and titrate it up and go slower. And so I had the second round on Thursday, and it did the same thing again. I reacted to it. They had to stop it. We had to restart it and go slower. So, I mean, is it just going to be burning me up like this the whole time? My whole body just feels hot, and it's like I'm having a reaction to it. And I've got 6 of these over 4 months. So is that what I should expect the whole time?
Guys, who's had a bunch of doses? Oh, look, Matt just left right when we needed him. But is RJ still with us? Yes, he is. RJ, talk to Danny.
I'm not sure that I have any information. So you're burning up when they're administering the docetaxel, right?
It's like a reaction. It's like a allergic reaction, and that's what it feels like to me. But it's just I have that nonstop even afterwards, and they know about it. And they're like, yeah, just take the prednisone, take the Pepcid, take the whatever, and it'll reduce the symptoms. But I mean, it's just hot. The whole body is hot. My face is hot. It's red. It's irritating, just like an allergic reaction, nonstop.
Yeah, I didn't have that reaction, but it's nasty stuff. It's poison that's killing the cancer.
Danny, did you happen to read the reminder for this session, Rick's reminder?
Oh, no, I'm sorry. What'd I miss?
Oh, that's all right. There was, I did a little piece on an article that Rick uncovered that talked about the usefulness of pharmacogenetics, pharmacogenomics in the treatment of cancer. So, you know, we all know that you want to look for certain mutations to see if there's a drug that can be effective against that mutation.
Yeah, I did read that. Yeah.
You did read it?
I remember the somatic versus the genetic and the symptoms and how we respond
exactly. to. So, you know, some people have germline mutations that affect the way they metabolize drugs, especially chemotherapy. You might be a slow metabolizer, maybe of docetaxel, and maybe your levels of docetaxel are very high, higher than other people would be with the same dose of docetaxel. I don't know if you can talk to your doctor about if you do any kind of a study there.
So, I mean, that's such a good point, Len, and you probably have the best doctor out there to address that in Antonarakis. Yeah. So you could write to Antonarakis, and you could clip Len's piece, and you could say to him, Dr. A, this is from my reminder, and I'm having a hell of a time. And do you think there are any clues in, you know, from my germline test as to why I'm having this issue? And I mean, he's exactly the sort of doc that we would say go to and ask, because he buries himself. If anybody understands it, my guess is it would be Antonarakis, right? Right, Len?
Oh, yeah. I agree.
That's a good idea. I do remember that article. I did read that right up, and that does make sense to pursue. So thank you for that.
Yeah.
Yeah, I mean, that might be a little bit ahead of current medical practice. But anyway, talk to Antonarakis about it. Like Rick said, show him the article.
Well, and I guess the bigger question was like, if every dose, the 6 doses that I have is like this, and they have to titrate up and go super slow. It took 3 hours instead of 90 minutes to get through the session.
Well, so, you know, the other the other discussion, I think what I might even do is ask if you can make an appointment with Dr. A and go in with your wife and go see him and say, you know, maybe I need a different dose. Maybe the dosage per square inch for me is it square meter or square inch? I never,
Meter.
I'm meter. The dosage per square meter needs to be adjusted, Dr. A. What do you think? Because this is how I'm doing now that I've done 2. And I think it's very reasonable to go in and talk to him. I mean, what would you say, John, Dr. John?
Yeah, I agree. There's no great magic about 6 times this certain dose. You can do fewer times higher dose or less times lower dose. There's flexibility that the oncologists can use. And in my limited experience, I haven't had docetaxel myself, but I've listened to a lot of guys who have. I don't see side effects diminishing as you go through the course. If anything, I see side effects increasing.
That's what I hear, and that was my concern: is if it continues to progressively get more intense, do we refactor the frequency and duration of a dosing, and do it more often, once every other week as opposed to once every 3 weeks.
Right. Right. And that's a real good, is a very good alternative, that you go to a lower dose every 2 weeks. But I think, and the other thing is, maybe you might be one of the guys who's better off on cabazitaxel rather than docetaxel. But all of these things you can discuss with Dr. Antanarakis, because he's very open to them. And that's what I would suggest you do. RJ, you had your hand up for a minute.
Yeah, I was just going to say more frequency. Like, you can do it weekly. Not that you would want to go experience that every week, but maybe it's not as bad if you do it every week over, with a less dose. Maybe your body doesn't have that same reaction, and it ends up having the same impact on the cancer.
Okay.
Yeah, I mean, I think, Danny, that given your response to these first 2 doses, that it's time to have a chat with Dr. Antanarakis and see, not just emailing him through, but you want to talk to him about this plan. Frank, do you agree with that? Frank, go ahead.
Yeah, I would say it's I just read about it, and I wouldn't even take a chance with it, Danny. I would gotta talk to your doctor. You have a hypersensitivity towards this medication, and that's what I'm saying. I'm just putting it out there, like, could be. Hey, I'm not saying what it could be, but yeah, that's a bad reaction, I'd say.
It is. I mean, not to get hyperbolic about it, but I couldn't talk. I couldn't breathe. I was like non-responsive, and
you need to talk to your doctor right there, man. Those are all the signs. That, they had, when I did it, I started feeling bad, and then they were able to fix mine. But yours are getting worse, man. Don't play with this, man. Please.
Yeah. And twice in a row, Danny. Twice in a row.
Please. Part of me wants to just power through it and get it over with, and the other is like, well,
I was just going to say, don't be a Marine. You don't have to be a Marine here, okay?
Yeah, I get it.
Right.
Please, man.
Okay.
Please.
Thank you, guys. I appreciate it.
All right. Thank you, Danny.
I could never. Sorry, but I could never finish my docetaxel. I could never finish my docetaxel. The side effects got so bad that finally a doctor said, I don't want it to, kill you, because I was getting rashes and swelling, and they said it could start to go to your organs, could have that reaction. So I lowered the dose a little, and I eventually stopped without completing the full cycle, but I'm still alive 7 years later. Just
All right.
God.
Thank you, Larry.
Protect yourself.
Yeah. First, do no harm, right? Okay, Thomas Siegel. Are you still with us, Thomas?
Yes, he is.
Okay.
You there, Tom? Tom Siegel? Come on in. Who's next? We'll go back to Tom Siegel if he turns on his.
Actually, Rick. Oh, I see him. Yeah, and his mic is on.
Sorry.
Now his mic just came on.
He's back. Go ahead, Thomas.
Okay, but can you hear me?
Yes.
Well, you know what? Today was an interesting day, and rather than talk about my details, I'm going to see 2 doctors in the next 2 days. I'll have much more thoughtful commentary on my state of cancer after I get back. But I did want to say just one thing. I have grown to really appreciate your materials that you write before the meeting. You talked about it today with and to me now, I don't know if I'm just getting older and older, but that kind of education that you've been imparting just on those papers has been wonderful for me. So I wanted to thank you for that. That's really my only comment for today.
Well, hold on a minute, Mr. Siegel. First of all, we're happy to do it. And we got some good stuff coming down the pike. I've been finding a lot of stuff the last day or two, at least for the next 2 or 3 reminders. I got plenty of material. Now, we want to just make sure if you've got something significant going on that you ask these doctors the right question. Yeah. And we'd rather you said something to us now than wait till next week if you're not sure what to ask or you want to bounce anything off of us.
Well, can I put it this way? I think I have some biases, and I need to have them worked on by these particular doctors who I trust. So that's why I'm saying that. For example, I'm at the 0.1% of who do not want to eliminate testosterone in my body, and almost everything I deal with on this is to do that. And I've got ways to work around that, but we'll see if they persist. But anyway, that's just one example. As bad as I'm going, and I'm getting more growth in the prostate. I've got 3 big tumors now. I'm still fighting it. I'll also tell you one bias. I did hear that one of your other doctors were 88 or something, but there's very few 80-year-olds that are active into this. And if you read the history of what happens in your 80s, almost everybody's on a decline. So you got to consider part of what aging is doing to your reaction to drugs and to cancer. So I'm getting that all kind of so I can make some intelligent comment when you talk to me about it next.
Okay. The one thing, and you can fill us in next Tuesday. By the way, Ben is going to be back to moderate next Tuesday. You can fill us in next Tuesday, but bear in mind that if you've got to go back on treatment, you always have the option of doing a monotherapy ARSI, a monotherapy enzalutamide or darolutamide or abiraterone or apalutamide monotherapy.
Yeah.
That doesn't take the testosterone out of your body.
Right. And by the way, I today alone, I appreciate it because I've heard that a few times. So once again, thank you.
Our pleasure.
I was not that aware of what I'm hearing until today.
Okay. And I've got to look at where are you getting your treatment, Tom? I can't remember.
Well, I'm going to Moffitt this week. Here in Florida, Moffitt.
Well, again, we are not big fans of Moffitt for a bunch of reasons. And we would rather see you, if you have advanced cancer, we would much rather see you with Dr. Guanchel at Florida Oncology Specialists.
And where's that?
I beg your pardon?
I'm not familiar
Sarasota.
with the name. What?
We'll put it in the chat window for you
Okay,
right
thank you.
now.
Thank you.
Len, do you want to just speak to that whilst I put it in the chat window?
That's great. Thank
Yeah,
you.
where do you live, Tom?
Well, I live in Holmes Beach, Florida, and the Moffitt Center is about 45 minutes for me, so that's convenient.
Okay, so you're north of Tampa, is that right?
Yes. No,
Okay,
no,
well-
I'm sorry. South of Tampa.
Oh, well, that's good because then Sarasota is a little bit closer to you, maybe.
Oh yeah, I've just had heart surgery there, so. Yeah.
Oh, yeah, great. Yeah, Dr. Guancha, the one we're recommending to you, is with the Florida cancer specialist in downtown Sarasota. She's excellent. I've been seeing her for quite a few years when I'm down in Florida. And so have a couple of other guys who dropped off the call now, but they all think she's fantastic.
Wow, thank you once again. Something new that I can deal with.
Okay, Tom.
Thank you,
Tom, I just put her link in the chat window. Elizabeth Guanchal, and the guys love her. And we love it. She's really, really good. She trained with one of the best docs in the country. Len's been seeing her, and I think she's more, in certain ways, more flexible, and she's better than the guys. I forget their name. Those guy, the Oriental guy, and the guys up at Moffitt.
Yeah.
Who are you seeing at Moffitt?
This is Dr. Patel, Patel.
I don't know him. And as a urologist or a medical oncologist?
Urologist.
Okay. Do you have it?
He's really good. I've talked to a lot of people working with him, so I can't comment really personally from one or the other, but I will see him one more time.
Okay.
He seems to be really understanding of a person's individual situation. Where are you? Time and everything.
But it sounds to me like you need a medical oncologist running your care, not a urologist.
Okay.
If you're in this group, which is high risk, recurrent, advanced, you need a medical oncologist running your care.
Okay. Thank you. I'm making notes.
And we'd say, Dr. Guanchal. Okay. And Dr. John just left Len, so he can't ask his question, but maybe you can reach out to him on the side and help him.
Oh yeah, okay.
Make a note. Make a note.
I made notes. I'm writing notes. Thank you.
Oh, you're writing notes. I'm telling my friend Len to write notes.
Go ahead. Good.
Yeah, and at the same time, tell him you're going to write up that study I sent to you today.
Yeah, absolutely. Great. Yeah, I don't know if I told you before, but one of the things that adds to my 84 is 2 years ago I was essentially considered dead from being hit by a car on a bike, and it does affect my brain. So I'm not as functional as I once was, and so I'm just compounding being 84 with a brain injury too. So, but thank you,
Tom.
Sounds pretty good to me, Tom.
Tom, did you see the link there for Dr. Guanchal? Did you click on it?
I haven't looked up there. I was busy making notes.
Okay, so click on that link or download. Everybody download before we close out right now. It's the 3 little dots at the top, or just click on anything.
I got it.
Tom, just click on that, Dr. Elizabeth Guanchal, and it will open up in your browser.
Okay. Keys.
Rick, that's it for tonight.
Okay.
We're going to wrap it up. Thank you all very much.
Thank you.
And we'll see you next week on Tuesday with Ben in the driver's seat. How about that?
Yeah. Okay. Goodbye, everybody.
Bye.
Bye.
Good night.
Good night, Sylvester.
Made it.
Love ya.
Same here.
All right, I'm closing out.